Thank you, sir, for those inspiring and thought-provoking words. Without further delay, let us commence today's academic program. To chair this session, it is my pleasure to invite Dr. Sumana Handagala, President of Sri Lanka College of Pulmonologists, to kindly come forward and take his seat on stage. Over to you, sir.
Right, we'll start the first session, and the first lecture will be delivered by Dr. Niranjan Disanayake, MBBS, MD, MRCP UK, FRCS London, FCCP SL, and FCCP USA. He's going to talk to us on bronchiectasis in Sri Lanka, an overview of challenges and way forward. And he's a consultant pulmonologist attached to Teaching Hospital, Kalutara district, and he is one of our active past presidents of the college, and he's the chair of Bronchiectasis Working Group, Airway Assembly, Sri Lanka College of Pulmonologists. Over to you, Niranjan.
Thank you very much, Dr. Handagala. At the outset, I would like to thank the President, the Council, as well as the Airway Assembly, headed by Saman Mali, together with Niranjan, for the excellent support given to us in organizing this interesting conference. And without further delay, we will go into the gist of the talk. So Sri Lanka is actually, very famous for mainly two things: the unique shape, giving the name Pearl of the Indian Ocean, and to the unique Sri Lankan smile, which signifies the beautiful, warm hospitality. But unfortunately, some of our patients suffer and they might not be able to smile. So let me start with two cases. Two patients who came to us within the last 1 month to the unit. A 47-year-old gentleman who has been repeatedly admitted to medical care in tertiary as well as secondary care hospitals, investigated and has been managed as asthma, presenting to us with a saturation of 70% in severe respiratory distress, and the chest x-ray showed bronchiectasis, and you can see the HRCT, and unfortunately this patient has severe pulmonary hypertension and we have to commence long-term oxygen therapy. Whether there was a delay in initiating the appropriate treatment, how can we improve it? Yeah, that is here what we are here for. A further unfortunate story, a 17-year-old girl with a product of consanguineous marriage, presented recurrently, according to the mother, with lower respiratory tract and upper respiratory tract infections to various hospitals, and treated as tuberculosis at the age of 13, and then presenting with this picture. So these two patients will be discussed further, but I want to highlight is that, there is a very important aspect in bronchiectasis in Sri Lanka that we need to concentrate about. And as clinicians working in secondary and tertiary care hospitals, we come across patients daily, not as only as pulmonologists, but as physicians, family physicians, general practitioners, in various phases. Bronchiectasis comes to us in various phases, and we see them on a day-to-day basis. Hence, importance of bronchiectasis is disease as a disease in Sri Lanka. I cannot elaborate more. So when we take a step back and look at the disease and the global perspective of bronchiectasis, René Laennec, in his landmark treatise, he described bronchiectasis is when he listened, he heard the cause crept, and in the autopsy that followed when the patient died, he noticed that chronically dilated bronchi, which is filled with thick secretions, and we know bronchiectasis to be a chronic disease characterized by recurrent respiratory infections and productive cough. And the hallmark and the gold standard is the HRCT diagnosis, seeing features of bronchiectasis. The story of bronchiectasis in 1819 started with Laennec, but it has a very important history. In the 30s, we identified bronchiectasis through X-rays. With the development of X-rays, it was facilitated. And then in the 1950s, the antibiotics actually came into the picture. And actually, the first inhaled antibiotic was started in the 1940s until tobramycin came in 1997. These were the initial steps in inhaled antibiotics. And then the microscopic diagnostic facilities improved. The importance of physiotherapy was recognized early as 1950s, and then the HRCT actually changed the diagnosis of bronchiectasis into a significant event. But we were struggling to understand the pathophysiology of bronchiectasis, and it is in the 1980s that the vicious cycle of colds was first introduced, and then it helped actually to understand this disease as a disease entity, hence to plan treatment options. Earlier it was identified as a disease that we can't treat and do much about except probably physiotherapy and giving antibiotics for the exacerbation, which were frequent in this patient. In 1999, there was a major breakthrough identifying primary ciliary dyskinesia, and it is a very important fact. I think it will be highlighted again and again during this conference because of the importance that it poses, especially in the younger age group. We can actually do something about it to prevent the complications. And then the guidelines came in 2010, just 15 years ago, for a disease that was identified in 1819. The first guideline was in 2010. So you can see the slow progression of the disease management paradigm, the projection. And then we identified severity assessment scores, and then the development of targeted therapy was rather rapid. After 2010, there was a rapid development in the management of bronchiectasis, where I tried to identify treatable traits, and precision medicine came into the picture, and various trials were undertaken, and now we have actually patient-based management in bronchiectasis. So during possibly the last 25 years, bronchiectasis has seen a huge change in management, including a specific drug that has been developed for bronchiectasis, paracetamol. And you can see that the studies have shown that the number of publications have increased markedly, and there are various registries that are now developing, including in Spain, America, as well as in India, where now we try to identify these traits properly and treat our patients properly. When you look at the global scenario, we know that bronchiectasis is prevalent. There is a slight difference between the Asian as well as the European subcontinent. And Asian, it is seemed to be more commoner. And this is a beautiful study by Dr. Rajata, who will be speaking after me. And he has identified that of the patients who he has seen, depending on the age groups, he has percentage-wise broken it down, and 41 to 60, 3.5, and as the patient age, they have noticed an increased prevalence of bronchiectasis. But what I'm interested is about the 18 to 40 age group, where he has seen about 0.5 to 1% of bronchiectasis, which signifies that there might be conditions that we might have to look into in these young patients. Bronchiectasis, even though we have defined it as a very simple disease, the definition is very simple than when you consider COPD and asthma, but there is a huge diversity of bronchiectasis depending on the region, whether women or men are affected, how old the patient is, whether the patient is exposed to smoking, how poor the lung functions are, the percentage of Pseudomonas aeruginosa, how prior TB affects it, and how non-tuberculosis mycobacteria is common in this group. And you can see that even in the Asian group and the European group, there is some marked difference, signifying that there is a geographic diversity of bronchiectasis, making that we have to have our own guidelines and management plans. And when you look at the etiology in our part of the world, post-tuberculosis bronchiectasis seems to be the common, followed by the post-infective bronchiectasis. But there is a huge proportion of idiopathic bronchiectasis, which we have not evaluated properly. And maybe some of them have immunodeficiencies and primary serial dyskinesias, which we have not identified. And sometimes it is unfortunate that these patients are not treated properly. It not only affects, the geography not only affects the disease and how it presents, it affects how we assess the severity as well. Now, according to this study by Embark India, by Rajata again, they have shown that the bronchiectasis severity index and phased behaves differently in severity assessment of bronchiectasis, where BSI performs better than phased in our cohort of people. And you will be hearing about severity assessment by Professor Tony D'Souza, and I hope that you will understand what this means. So other than that, so bronchiectasis is, even though it's a simple disease, geographically it is diverse in this patient group. Presentations, it is diverse, and at the same time, clinical severity assessment is diverse, and at the patient level, it is a diverse entity as well. The severity is different from patient to patient. The activity is different from patient to patient, and the impact of bronchiectasis to that particular person is different from patient to patient, including how it affects the psychological and the social and the economic impact as well. So it is basically a diverse disease with many, many, many phases, hence the need of unique patient-centered, country-centered, patient-centered diagnostic as well as management strategies. So that is the importance that I'm trying to highlight. So when we look at Sri Lankan perspective, when you look at the critical perspective, when you look at the South Asian region, India and Sri Lanka, according to the available studies in Sri Lanka, age-wise, we are more towards the European cohort. Our patients are a little bit older than the Indian group, but younger than the European group. And the women are more in the Sri Lankan cohort. Age-wise, we are towards the European model, European group. Never smokers, it's almost the same. We have almost reduced lung function in compared to the European cohort. Pseudomonas, it looks the same. Prior TB, Sri Lanka has a less prevalence according to this study, and in non-tuberculous mycobacteria, we have a high prevalence. So even in the Asian subcontinent, we are different in various aspects. So I went through some research in Sri Lanka to see whether this is there. So this is a study by Professor Dushanta Madagadara, who has tried to identify the etiologies in a cohort of patients, and they have identified variable etiologies: allergic bronchopulmonary aspergillosis, Cartneger syndrome, and possible disorders of ciliary dysfunction. This is a very important area that we have to investigate further in the Sri Lankan context. And when we are looking at the factors associated in bronchiectasis in Sri Lanka, the normal associations are there: the female gender, coexisting cardiovascular disease, the age more than 60, rheumatoid arthritis, as well as importantly indoor air pollution. And it is one of the important causes in Sri Lanka as well as in the subcontinent, especially the air pollution. The biomass fuel exposure might be a significant risk factor in our female population mainly. And again, a case series of trying to identify treatable causes by Dr. Anoma Siribadana, published in the University of Peradeniya Proceedings, and we can see that she has actually excluded post-tuberculosis bronchiectasis and tried to identify treatable versions, and he has identified actually hypogammaglobulinemia, relapsing polychondritis, myelodysplastic syndrome, allergic bronchopulmonary aspergillosis, and so there are some treatable diseases in bronchiectasis if we try to identify the etiology where the patient's outcome can be improved even in the Sri Lankan context. So how do we identify the Sri Lankan bronchiectasis fingerprint? So the most important aspect is that we have to have a registry of bronchiectasis so that patient characteristics can be analyzed, and I hope that we can go towards that. So the other important aspect is that Yes, we need the data to identify the patient characteristics, and however we have identified the patient characteristics, the medical professionals' knowledge, attitudes, and practice will affect the outcome of their patients. And this is a study that our unit did, and I would like to highlight Nirodhini, my DTCT trainee, who actually presented this study at the Hanover World Bronchiectasis Day Conference. We actually got we've sent questionnaires to the physicians, internal medicine, pulmonologists, family physicians, general practitioners, doctors who are at the chest clinics, and tried to get a feedback of what the knowledge, attitude, and practice are. And we got about 98 responders covering 8 of the 9 provinces in the country. Average knowledge, good knowledge is there, positive attitude is there, good practice was there in summary. So we are in the green at the moment, but okay, we will go into a little bit of detail. So when we look at the sample characteristics, I would like to thank my colleagues of the college who responded the most, and then the family physicians together with district chest clinics, general practitioners, and internal medicine. So we see a little bit of low internal medicine participation, but hopefully it will improve in future, because they actually manage most of the bronchiectasis when the patients admit to the hospitals. So the knowledge assessment results, most of them knew that the HRCT is the gold standard, and physiotherapy was mandatory, was known by most of them. Bone scan was not recommended ideally, since that they know how to basically investigate these patients in the proper way most of the time. Whether Pseudomonas was a common pathogen, what I would like to highlight is that about 30% didn't know that Pseudomonas was an important thing, not the positive one, the negative one. Whether the patient needs long-term antibiotics, around 23% to 25% didn't know. The diagnostic criteria was not clear in a certain groups of people, and the etiological factors were not very properly known in certain groups of people. So there is a knowledge gap. We can't be happy that we are in the green, because when we subanalyze, there are certain knowledge gaps that we have to identify. So knowledge by specialty training, the internal medicine has actually beaten the pulmonology. So anyway, but you can see that the knowledge and the specialty has a little bit of a correlation. And the important other thing is that when you have training in bronchiectasis, the knowledge was high as expected. So this includes the diploma trainees as well as the consultant pulmonologist who has worked in bronchiectasis center. So obviously their knowledge will be high. But one important outcome I want to highlight is that there is only 2 significant things that had appeared. Prior training obviously is associated with good outcomes, and it highlights the importance of training and having continuous medical association. And the years of experience is negatively correlated. That means the senior you are, the knowledge seems to be less, saying that there is a knowledge decay. So that there is a need to continually medically upgrade our knowledge, especially when you become more senior. This is not applicable for our senior colleagues, but most of the time the age and everything is affected. Right. So the attitude, they knew that continuous medical education would improve patient care. They agreed that physiotherapy is underutilized. BTS guidelines were locally applicable. About significant proportion said yes, but there is a significant proportion who said non-committal or no, probably indicating that we need our own guidelines. Medical practitioners unfortunately felt a little bit unconfident in diagnosing bronchiectasis sometimes, as well as long-term antibiotic use. There seems to be a little bit of a knowledge gap as well as practice gap, attitude gap in long-term antibiotics. So we need to address that gap. So they always refer to physiotherapy, but unfortunately 25% don't. Physiotherapy came in 1950s, but still we lack that thing. And 30% doesn't follow a guideline, whatever the guideline is. About 35% says that they don't encounter Pseudomonas, which is rather intriguing. Maybe it's a little bit low, but it is there. And investigation facilities were not available in certain areas, and antibiotic protocols were not followed, and sometimes the HRCT is not ordered in all patients, probably due to the practical reasons because of the dearth of HRCT facilities. Hence, specifically, they know that HRCT is the gold standard, but about 50% don't order HRCT simply because I think there is a delay in getting an HRCT. That is one thing that we have to ideally do. So the major gaps are HRCT they know, but they don't do. Maybe because of not having HRCT facilities freely. Chest physiotherapy, they know, but some of them don't do, most likely because they don't have the facilities of a physiotherapist. And the physiotherapists are overburdened. Microbiology culture, 60% does, but about 40% are not very sure about it, maybe because of lack of facilities. So even though we have some positive etiological, positive important factors in this study about the knowledge, attitude, and practice, there are a lot of things that we have to do. So CME programs, yes. Formulate the Sri Lankan bronchiectasis guidelines. I will go into it a little bit later. Priority infrastructure investment is a very important thing, specifically asking our radiology colleagues to help us in expediting HRCT and improving the facilities for HRCT, at least in major centers, so that we can diagnose these patients and classify these patients as well as start appropriate treatment in these patients. Not having physiotherapists trained is a major deterrent in managing our patients with bronchiectasis. We probably need specific respiratory physiotherapists for this matter, trained in airway clearance techniques, and then we need a bronchiectasis registry, and we have to integrate bronchiectasis management into the undergraduate criteria, and that's why I wanted to stimulate our medical students, and I'm really happy and proud. And one of our medical students will be presenting a case today. So we want to give them the opportunity to get knowledge as well as highlight themselves as well. So there is very important things that we have to do, and basically I think I'm happy and humbled to say that Nirodhani won the Best Poster Award for this presentation in the World Bronchiectasis Day Symposium, and this is basically a teamwork that we usually do, and Nirodhani is at the center there. So Sri Lankan bronchiectasis, the future, few slides. We need to address this gap as a college and as a specialty and as a country if we want to go forwards, and maybe we want to recruit more people into these studies to actually see the gaps and identify how we can correct them. Towards identifying the Sri Lankan bronchiectasis fingerprint, we need the bronchiectasis registry, and Dilesha is here. Even in the morning we were discussing about it, and maybe the next bronchiectasis day we will be able to present our initial findings, hopefully, and I'm happy that our foreign colleagues are very, very enthusiastic in helping us, including Dr. Rajada as well as Professor De Souza. And I would like to pay homage to Dr. Amita Fernando, because there was a lack of guidelines in bronchiectasis, Sri Lankan guidelines, and he, being a senior pulmonologist, together with the senior registrar, Dr. Rasun, has provided this guidance to us, and it is a very good starting point, and it is very comprehensive, and hopefully from there onwards, Dr. Handagala and the Airway Working Group, we can go forwards, and maybe by the next year we will be able to present the first Sri Lankan guideline in bronchiectasis, which will be unique to Sri Lanka, so that our people can benefit. CME activities, we know that it is important. That's why the college tries to integrate most of the Sri Lanka Medical Association, Sri Lanka College of Physicians, as well as in the regional meetings. Bronchiectasis is always highlighted as an important disease in our conferences, so improving CME activity amongst doctors, because there seems to be a knowledge gap as well. So even though these patients they have suffered a lot due to this disease, which is actually not preventable but manageable, rather than going into this extent. I think if we work together, we might be able to achieve a lot in Sri Lanka. if we work together as a multidisciplinary team, as a college, with the ministries, with the patients, with the stakeholders, I think the future of bronchiectasis in Sri Lanka will be a unique entity. And hopefully by next year, we might be able to keep the first baby steps in improving our patients' outcomes in future. Thank you very much, ladies and gentlemen.
Thank you very much, Niranjan, for that inspiring and very detailed overview of situation of bronchiectasis in Sri Lanka. Have you got any burning questions? You can shoot any questions if you have online, or no questions in the chat room. No? In fact, as he mentioned, bronchiectasis we learn in the medical school during third year and fourth year for pathology. After that, 1 or 2 cases in the final year, and since then, until we come for the postgraduate and pass in MD part 2, when I became SR in thoracic surgery only, I started seeing this many cases of bronchiectasis. In fact, you must be seen as chest physicians, a lot of bronchiectasis. It's not very common, but there are so many patients around suffering silently.